Hi, I'm Josh McDonald.
And I'm Miranda Viteri, and we are Hand Therapy Academy.
So let's talk about everyone's favorite protocol to hate on, Kleinart. Let's talk about the Kleinart Flexor Tendon Protocol. It's been around for 50, 60 years, and it's what everyone kind of raises their nose at and says, this is old, it's out of date, it's bad medicine. Well, let's talk about it, and maybe when is a good time that you should use it, or does it cause that many problems to begin with? Is it still an effective treatment approach? So let's talk about Kleinart.
And first, I would say, when was the last time you did a Kleinart?
I would say I've done one Kleinert patient, and it was probably, let's see, 7 years ago. And the doctor was super worried about this patient's ability to be compliant, how tenuous the repair was, and just everything sketched him out. And he said, you know what? Go back to Kleinert and use that. I'm like, are you sure? He's like, yep, I know. We're going to get PIP stiffness because it's always pulled into flexion. I know we're going to get that. Go use it anyway. I don't want him to rupture. Protect my repair. Okay, great. We'll do Kleinert. And so we glued a hook to his fingernail and we ran with it. And the patient had okay outcomes.
Did they have to
He
have
wasn't super compliant. Yeah, he wasn't super compliant. That's why the risk. But he turned out okay as flexor tendons go.
Interesting. I got one probably like 4 months ago.
Okay.
And I remember I called, it was a doctor, and, he was a little further away, but it was like someone I kind of knew. It was her brother, and she wanted me to see his brother. Okay, so no big deal. I called the doctor. I was like, is this what you want? He's like, yeah, I sewed the loop. So there was already like a loop sewn on the fingernail. So I
Okay.
could hook the rubber band to it. So I was like, well, that's nice, because I feel like half the battle with Kleinart is keeping the hook on. So that's what we started with, and he wanted to do that, and I was fine with it. And I'm like, okay, well, I know these outcomes are, going to probably be okay, but actually the patient was so stuck,
Interesting.
like
Stuck in
very
scar?
stuck in scar.
Okay.
But
Okay.
also, I don't know, like, was a pulley bent? I don't know. I didn't know, I
Yeah.
like the surgeon that well, and but
Yeah.
so I didn't know what his typical outcomes were either. So
And so there's an article by Rebecca Nadusky that's probably 3, 4 years old now. I think we've referenced it a couple of times. And she did a good job of comparing outcomes on patients with all the different major protocols.
did
Kleiner modified.
she publish that, or was that just her talking about it? I thought she was just talking about it.
That could be. That
I
could
think
be.
so. I know we talk about which. I think it was I think she presented it at a conference. The outcomes.
Okay.
I don't know. I don't think it's in print, but I could be wrong. But
Okay. But basically, the patients were getting good outcomes on variety of different protocols. That that as long as you're doing no harm and you're protecting the repair, that there are good outcome potentials with all of these. We come up with new versions because we say, hey, here's a better way to do it. But all we had was Kleinert 70 years ago or whatever, patients were still coming out okay. Now we know how to get them stuck in less stuck in scar, but this isn't going to cause them to rupture. You maybe have some complications, but if a doctor really wants you to do that, it's not like you're doing bad medicine.
yeah, and I always tell my team, like, one, we're not going to badmouth our surgeon, right?
Yeah.
That's the leader of our team, right? We're going to support him, and if this is what he wants, if we don't agree with it, then call him up and have that conversation why you want to do something different. But you're not going to tell the patient, we're not. I don't know. I think there's a lot to be said about trusting the person who's doing the procedure, right? So we need to trust what he sees intraoperatively and what he wants and his previous experiences.
Yeah. Yeah. So let's talk about a little bit about what Kleinert involves. It is, you see them right off the bat. You put splint them with the wrist in 40 degrees of flexion and MCPs in 40 degrees of flexion. And then I'm going to put a rubber band on a hook that's usually glued to their finger, unless they've gotten it sewn on. There's some other options there, but that attaches to a rubber band that comes down and anchors to the proximal forearm strap. There are a couple modifications that have come out since where they say if it's FDP, I should hook all of the fingers because of the common muscle belly. And they're now suggesting that you pulley that on the distal palmar crease strap because pulleying it on that adds DIP flexion. So It loops through, and you can run a monofilament through little slits in that strap. You can add like a sew on a metal pulley. Lots of options to do that, but basically it needs to route through that distal palmar crease strap and then down to the forearm with a rubber band component. And so what you're going to do at like, I think it's 2 weeks, you're going to take that wrist back to neutral. So I will re-dip it and make the wrist in neutral. But for the first 2 to 3 weeks, it's going to be in that 40 degrees of flexion. But they're going to do active exercises against that rubber band. So it's active extension against resistance of the rubber band into the dorsal blocking splint, and then passive flexion down because the rubber band is pulling them. Now we know that it's not completely inactive flexion. We know that when you tell your brain, shut off, your flexor muscles still do something, but the idea is 10 to 15 times every hour, I'm doing active extension to the block, and the rubber band is passive flexion back down.
Yeah, and that's pretty much it.
Yeah, yeah.
Right? I mean,
there's more to like how you progress them at different mile markers, but it starts to look very similar to when you wean them out of the splint, when you add strengthening. But it's that rubber band is your safety net to say they're not going to overextend and they're not going to do active flexion because the rubber band is the flexion component.
But you're kind of hoping they might do a little active flexion, right?
Yeah, and like I said, we know that when you try to eliminate that entirely, they're still going to do something. Like with a radial palsy splint, they're still doing some of that activity, even though the rubber band's supposed to be doing all of it.
Right. So we know there's a little bit of cheating going on, and that's okay.
Yes. Yeah. And so when it's time to make one of those, you do have to have some unique materials. You got to have monofilament. You may have to have line connectors unless you're a Boy Scout and good at knots. You have to make sure you've got a hook and some super glue to glue a hook onto the nail. And you may have to redo that every once in a while. You tell them, if it comes off of your finger and pops off in the middle of the day, come back in and we'll glue it back on again. and what to do to keep it down in the meantime.
Yeah, and honestly, when the surgeon put that loop on, it was so easy because we just connected to the rubber band to the loop, and then made the palmar piece, so we could get that composite flexion that you were talking about. But it did make it a lot simpler. Like I was like, oh, this is great because we don't have to mess with the hook. We don't have to have a connection, whatever you're going to hook around I guess you could hook a rubber band around the dressing hook too that you put on there, but.
Yeah. And I've seen that where it was like the finger was dressed in gauze and then you like embedded a hook in the gauze and wrapped it on that way. That's an option too. It just kind of depends on what wound care and dressings they need.
Yeah. And then there's Band-Aids. You could hook them on with Band-Aids. Honestly, it's a pain though. It's really a pain to get the hook to stay. So if you do have, I would say if you have a surgeon that's doing a lot of those and they want you to put the hook on, I would say, hey, would you mind like sewing a loop on it? Because then when they go to it's time to take it out, you just cut it and pull it out through the nail.
Yeah.
It's so simple.
It functions a lot like a button from the FDP pull through. Like if they're doing a button approach, it kind of pops through the nail like that. And it's very easy to trim off.
Yeah, it makes it so. I had never had a surgeon do that for me, and I was like, that's my guy.
Yeah, right. Yeah. Absolutely. I almost forgot there is a nighttime component piece in the first couple of weeks of that splint because they can't wear the rubber band all night. It's going to break. It's going to get caught on things or come off entirely. So there's a volar piece to the fingers that you make that straps on and then sandwiches the fingers up against the dorsal block. So it's just an extra piece. You don't need the sticky back Velcro over the fingers because there's no strap holding them up. So now the sticky back Velcro that is there is just waiting for that nighttime pan that kind of clamshell sandwiches those fingers into that dorsal extensions position.
Yeah. So still an okay option.
Yeah. You get some complications with it. If you're not doing the rerouting through that palmar strap, you're going to end up with a little bit of PIP flexion contracture. You might end up with some of that anyway because it's PIP flexion almost all the time except for their exercises, so that you may get some flexion contracture there. It's protecting the repair, but scar may set in and get a little bit stuck down. Yeah. So there are other options besides just what we were comfortable with. And, let's be nice to Kleinart. He came up with a good option for us, and it's something maybe you'll use and you can still get good outcomes with it. But if you have any questions for us, don't hesitate to reach out to our emails, info@Hand Therapy Academy, or on our social media platforms through the handle Hand Therapy Academy.